You are watching the Wellness Hour, leader in medical news and information. I'm Randy Alvarez. What you need to know about low vision, new breakthroughs for people across the country without surgery. With us, we have a professor from Western University of Health Sciences.
That is
Dr.
correct.
McAllister, welcome to the program.
Well, thank you for having me, Randy.
All right, now what is your role there? You're a professor.
I am.
And what is your official title, by the way?
Well, I have two titles. Okay. One is Chief of Primary Care, which has to do with the entire clinic, and the other is Chief of Low Vision. Okay. And that means I help run both clinics in conjunction with the other professors.
Okay, good. You know, I heard about your organization through an ophthalmologist.
Yes.
He said, Randy, the public doesn't know that they could use the university for their vision needs, and you're trying to get new patients. Is that right? And I mean, who can go to the university to get?
Well, our eye care clinic has two main thrusts.
Okay.
One is excellence in patient care. One is excellence in clinical education. So both of those things are very important. So in order to teach our students well, we don't just model excellence, but we have to deliver excellence. And then we mold them along that path. So the patient gets not just the advantages of all of our new technologies, but they get the advantage of a number of professors who have been out quite a while. There's a few gray hairs among our professors, and they've been around the block a few times.
Now, are there a lot of people that don't know you can go to the university for eye care?
There are. Our clinic is only a couple years old now, and so people tend to do things by habit. And when they get into habits, they just tend to do it. Inertia just keeps them doing the same thing. And we like them to maybe turn them off their old way of doing things and to try our way of doing things. We call it the Western way.
Okay, and we're talking about low vision.
Correct.
And I think the first part of our segment, we're going to start with the adults.
Okay.
Okay, seniors in particular, and what can be done. And then, of course, we'll talk about pediatric vision and what the parents need to know about their kids. But let's start with, before we went on, I said, in a perfect world, who do you want more of? What kind of, and you said, I want people, well, go ahead and say it.
Well, if people tell you, the doctor I saw last gave me these glasses, or the surgeon I saw last said, I've done all the surgeries, or the physician said, you've had all the medications, and I still don't see well enough to do what I want to do. That's the kind of person
you want more of those people.
You betcha.
And there's things you could do without surgery, is that right?
Well, you bet, but typically we work with the surgeons. We don't do magic, we don't do miracles. What we do is we take people who have come to the end of their physical, their pharmacological, their surgical, their glasses rope. We take them there and then make the best use out of what they have remaining.
You call it low vision rehabilitation.
Correct.
Is that right?
Yes.
So give me the categories of the adult patients that you see.
Okay, the number one cause of vision loss in Americans under 65 is diabetes.
Okay.
The number one cause of vision loss for Americans over 65 is macular degeneration. Both of those are scourges. They're both increasing dramatically. And there's more things that go on with the person than just their vision loss, which is why at Western University of Health Sciences, we work with interprofessional education. And so we work with podiatrists because diabetes is the number one cause of amputations in America. We work with physicians because the diabetics have to get healthy.
Okay.
And we work with the pharmacists because they have to get their medications balanced and titrated just right. So we actually have the Western Diabetic Institute where the patient sits in the room, the doctors come to the patient. So each specialty comes in and deals with that. So the patient gets holistic care.
And it doesn't have to cost a lot of money to go there. I mean, you have some kind of a special, what do you call it?
We have a sliding scale.
Sliding scale.
So we accept insurances.
If you have very little money.
Yeah. Yeah, you just bring in proof of insurance, and there's techniques that the receptionist can help the people with, how they do the proof of insurance.
But everybody qualifies, right? I mean, even if you don't have any
insurance. We
never
turn anyone away.
And you'll work with them based on income.
You bet.
And they're getting all the new stuff. But would you say that there's tens of thousands, millions of Americans over the age of 65
that
have poor vision? They've been told there's nothing else you can do. You just kind of have to. It's going to.
Yes.
Then something could be done.
It's interesting you say that because that's what doctors do. Now, we all have boxes we fit in, and when we get comfortable in that box, we stay there. And doctors are just people too. And so when they get into their box is, I can't do anything more for you. But what they say is, nothing more can be done. And that's not the case.
Okay. So give me an example, by the way, of somebody that was told, given this diagnosis, nothing else could be done, but you worked with them and now they can see better, function better, or whatever.
Okay, you had mentioned the ophthalmologist earlier.
Okay.
Great surgery. They made great breakthroughs in the last 20 years. Just in the last few years, injections for wet macular degeneration, which used to be basically a blind sentence. Nowadays, it's not. Nowadays, you get injections in your eye, and it halts the progression. Now, once that's successful, success means something different to a surgeon. A surgeon's success means I've done what I'm going to do. But then we look at it and we say we want to make them see better. So success to the surgeon is I've done a good job. And you're darn right, they have done a good job.
Okay.
But we want to do more than that. We want to take that good job and enhance it. And we do that with functional approach. So for instance, patient comes in and they're seeing 20/40, 20/50. 20/40, you can pass a driver's test. 20/50, you're no longer able to read normal size print, newspaper books. Okay. At that point, with the best glasses, we're done, they say. But we want to take them and get them seeing better than that. So for instance, when a patient comes to me, I have to manage expectations because all their lives, in our culture, glasses make you see. Glasses don't make you see. Glasses focus light.
Okay.
And so I tell them when they walk in, if glasses made you see, you wouldn't be here. So we're going to do other things. Now to teach you.
I mean, are there people that couldn't get a license and with your techniques at the university now could get a license? Has that ever happened?
Oh yes, for children. It's a rite of passage for youngsters. We're changing from age, in age groups here.
Okay.
It's a rite of passage, a driver's license. Now, like I told you at the beginning, I don't promise miracles, and we don't deliver.
But has it happened, by the way?
Oh, you bet. You bet.
Or even seniors that couldn't pass that test?
Yes.
Couldn't get a license, and now they can get a license?
There's two main paths to that. One is what we call a low vision refraction, and one is bioptic telescopes. Both of those things have been around for a while, but the mindset of eye doctors has tended to be more focusing on the health and the surgical aspects. Nothing wrong with those. Those are important. They're necessary.
Okay.
But like I tell my patients, each step in the process is a link in the chain. The chain of vision is only strong as its weakest link. If you have every link strong, except one, that chain of vision is going to break. So what we're going to be doing is trying to enhance each link to its maximum. And then we're going to see what you can really do.
With therapy?
With devices, with techniques, and with training.
Okay. And so what are and by the way, let's talk a little bit about you, your background, your training. How long have you been doing this? And why is this your passion, by the way? I mean, because you get excited about it.
I do get excited about it. This is, well, because I've never examined eyes in my life. I take care of people who happen to have eyes. What I'm looking at is to make people live their lives better. Nobody wants glasses. Nobody wants surgery. Nobody wants medicine. Nobody wants laser. They want to live their lives free of the encumbrances that come with those things.
All right.
So those things are just tools to get them to move on with their lives. And so when I see them, I have a different set of tools in my toolbox as a low vision practitioner. So I get.
So this is almost like a subspecialty. Low vision is your subs.
Yes, I think of low vision optometry as optometry on steroids. Okay, this is optometry to the max. You never see more pathology, more optics, more of anything than you do with low vision. So if you can do low vision well, you can do just about anything in eye care well.
But back to your background and training. I mean, how long have you been doing this?
30 years.
30 years.
I graduated from the University of California, Berkeley 30 years ago, and I had my mentor there was Ian Bailey, who I think of as the god of low vision. He invented the systemization of low vision and how to actually pursue a programmed task. So rather than just grabbing a magnifier, doing a hodgepodge of picking this or picking that, we actually had a systematized version of process. And so I've been in private practice 29 years, teaching 1 day a week at specialty clinics because it was my passion. I also tend to get bored easily, so I do enjoy doing more than one thing. So when the opportunity came up at Western University, and Western University College of Optometry has 4 pillars of distinction. One of those pillars of distinction is emphasis on rehabilitation. That's my...
Getting them to see better.
Getting them seen is only part of it. Seen is just...
Okay.
Seen is not what the goal is. Living their lives the way they want to live is the goal. If they need to see better, that's part of it. If people's vision is so degraded to the point that vision no longer provides any useful input for certain tasks, we go into what we call vision substitution. So vision rehabilitation or vision enhancement uses lenses, techniques, electronics, telescopes. Vision substitution, on the other hand, are things that take the place of vision. This is braille, canes, dogs, to voice readers, computer devices. So whatever it takes to get this person doing what they want to do, that's what we do.
Okay, now for people just tuning in, we're here with a professor of optometry at the Western State University of Health Sciences.
Without the state.
Without the state, Western University of Health Sciences there in Pomona
Yes.
Eye Center. And you're saying that you want, and I want to make sure we get this right, and one of the reasons why we have you on the show is that the university, because you're teaching other optometrists, that you need more patients for training doctors. And people need to know you're there and you're available, and you have this sliding scale. So if you have no money or very little money, actually no money left over, you could still be a candidate to go to get your...
Indeed, but that makes it sound like we're practicing on patients. We're not practicing on the patients when the students have already learned this stuff. And so what we're doing is having them put into practice what they've already learned. So the patients are getting full care from the doctors and the interns that already have learned this stuff, but are putting into practice that stuff so they can become better.
Pretty good too. You're also getting a more enthusiastic doctor.
You betcha.
Right?
And you get more time. In private practice, the demands of money are always there. You cannot get away from it. Even at the university, we have those constraints.
Good point, good point.
However, we can take as long as we want. We can take an hour, we can take 4 hours. And there's times we do take 4 hours.
Okay, okay. And would you say, by the way, now listen, and we talked on the telephone, that you say that there are people that in their 65 years old, can't balance their checkbook, they can't do their daily activities, and for them, their goals or their self-esteem is affected by this. And so
dramatically.
There are people that you can reverse this. It doesn't have to be that way.
No.
Would you say there's 1 million people that...
Up to 4 million in the United States.
That have this problem, could be corrected?
Ameliorated, yes. A big word.
A
big word meaning we can lessen the impact of this on them. So where people's identity is tied up many times in what they can do.
Okay.
Okay. And what they want to be able to do in their private times, they want to read. That's the number one thing.
Is that what they say to you on the consult?
People don't always tell you what they want. As I tell my students, you hear with your ear, but you listen with your heart. Okay? What do they really mean when they say something?
So they have low goals when they come in? That means that they don't even think that they can...
Most of the patients we see in low vision have had failure after failure after failure, which is why they're to us now.
Okay, okay.
So the general practitioners can't take the 4 hours, perhaps. Or they understand that low vision is available, but they don't want to include it in their practice. Low vision is often thought of as a charity. So when they come to us, they've already had a series of doctors who said nothing more can be done for you. When what they mean is, I can't do anything more for you in my specialty. And so when they get to us, we want to manage their expectations.
So the things that, and I interrupted. We were talking about can't balance their checkbook, can't do daily activities. Give me the life of this type of person with low vision and what could be done.
There are so many cases like this. It depends on the person. Almost everybody wants to keep their accounts private. Okay? They want their checkbooks, their bill paying.
Good point, okay.
They don't want to have everybody know their business.
So the neighbor might do it or whatever.
Child, it doesn't really matter. Somebody from the church, it doesn't matter. There's something about the privacy of your finances that you want to keep to yourself. It's an empowerment also. When you have to give up your finances, you're giving up a lot of control of your life. You're turning control of your life over to someone else.
Okay.
And that may not be what you want to do. Reading the newspaper, although newspapers are turning into digital nowadays, but seeing the control on the TV when you want to change the channel, you can't read the screen.
channel guide, okay.
You can't see the guide on the screen. Something simple like that. Seeing at the store, go shopping. Okay. One particular person just jumped at me in my head. One of the greatest psychiatrists of the 20th century was a patient who came in because he was still busy. He was old. In fact, when he walked in the exam room, I said, well, I can't say his name. I said, "Doctor, I thought you were dead." Because he was old when I was a student, okay? But in any case, he wanted to read a little better. He wanted to be able to do his own private writing again. Through some devices and techniques, we were able to free him from the scourge of having to dictate to somebody. Because, as the Librarian of Congress once said, Daniel Bornstein, I write so I know what I think. And so, if you do the process of thinking something and outputting it through your muscle memory, and putting it down, you have to process that.
So you
then
have
know
people
what
that
you're
are
doing.
writing and reading and balancing their checkbooks that were told there's nothing else can be done.
That's exactly.
Is that right? I mean,
That's
they
code.
say, hey, how come nobody else told me that? I mean,
I hear that almost every week. How come nobody didn't tell me about this?
Really?
It's becoming less and less because this kind of field, like I was telling you, when I graduated, this was a nascent field, just beginning to get started. And so now more and more and more. For instance, in the Academy of Optometry, there about 10% of optometrists are fellows, and about only 60 in the world are diplomates in the low vision section. And I'm one of them.
Okay.
But we get
60 in the world, and you're one of
60
them.
in the world. That doesn't mean I'm better than everybody else. And I don't hold myself out as better. But I'm involved, okay? And I want to spread the word. This is something that doesn't have to be a disability. It's something that
I mean, have people been to other optometrists, well-trained optometrists, that there's really nothing?
That's one of our best referral sources.
Optometrists give you the tough ones.
Yes.
Okay.
When they get easy low vision, that's the definition. Easy low vision is they can take care of it. So we tend to get the ones that have had the most surgery, the most injections, the most trauma, the most difficult cases.
And for some people, it's a miracle, life-changing.
Life-changing. We don't do miracles.
Do they ever describe it as a miracle?
They do.
For them?
They do.
Okay.
And I'm not going to do that.
Okay, you're not.
But,
okay.
But when you see their lives change, when you see that they can travel independently, when you see that they can go to the store by themselves, or you can just drop them at the mall and pick them up later. Maybe they can't drive anymore, but they can go shopping on
What
their own.
holds them back? I mean, if the therapies and the techniques you're using,
Mindset.
why aren't they all doing it?
Mindset. In our culture, typically people think either you see fine or you're totally blind. There's that huge middle of at least 4 million people in America that have partial vision, this low vision. In other words, with the best correction, they don't see perfectly, but they're not blind. And so that's just a cultural mindset. People put themselves in the box just like the doctors do. And they say, I believe what the doctor said.
So it's a label that they don't need to hang on to.
It's a self-imposed leash.
Now, by the way, something dawned on me because people are watching this, they're flipping through. If you have low vision, maybe you didn't see the channel guide.
Exactly.
And so if you or a loved one needs to know this, we'll put it on our website. They just put under low vision. So low vision on wellnesshour.com, and then we'll have it on your at the university website. They could find it there because my hunch is people are going to have to direct the loved one to your site.
Correct.
Okay,
And
so
often,
I interrupted. Go ahead.
It's very interesting you say that because it depends on how motivated, the patient has to be motivated because you don't just put a pair of glasses on and they see fine.
Do they say, I've tried everything?
They do. I tell them, I'm going to take you back to first grade and I'm going to teach you a new way to read. That if you did it when you were in first grade, the teacher would have wrapped your knuckles, at least when I was growing up, and said, don't do that. You have to hold things close. You have to hold one eye. You have to get a device here. You don't hold it out here and just read with your eyes. Okay? We're going to teach you a new way. So I want you to forget the way you read before. I'm going to teach you a new way. Okay? And that's how we get them started.
And you have some fun there too, by the way, because you have a big sense of humor. Do the rest of your team, the staff?
I love life.
Okay.
And I love freeing people from the shackles of their own self-imposed limitations. And I love freeing them from of being homebound. People that just sit at home, listen to the radio, have a blurry TV going. These are people I want to get out.
Really?
Now, that said, it really depends on the motivation of the patient because we were talking about they have to want to be able to do this.
Well, then talk to them for a second. Okay, so they're watching this.
Yes.
They know everybody wants to see better if they can't see.
Right.
Is it more about their limiting belief that everything's been done or there's nothing you can do?
That's part of it. Part of it is that the doctors they've seen have told them,
okay,
that's it. Instead of saying, I can't do any more, they say no more can be done.
All right, all right.
That's code for call us.
Because 60 guys in the world have your training, have diplomat training.
Diplomate training, yes.
Okay.
Yeah, and again,
I mean, low vision is this, a subspecialty in optometry.
You bet. Yep.
And
it's one of the fastest growing.
And a lot of optometrists don't want to deal with, I'm picking up on maybe this low vision patient because it's a tough patient.
It's a tough patient. It takes more time, and they just as soon send them to us or just have them go away.
At the university, maybe you have more time.
We do. Now, interestingly, the wars in Afghanistan and Iraq have brought back a whole new population of people with vision disabilities.
Okay.
The VA has taken this to heart, and they have opened up a huge number of low vision facilities. When I was trained back in 80 and 81, originally there were maybe 3 low vision centers for the VA in the country. Now there's over 50. It's dramatic improvement.
Do the eyes learn to see better?
Vision is in the brain. And so no one's born knowing how to see. You're born with maybe 21,000 vision. We learn how to see. And so if you don't train it, you won't see well. Now you may have good eyes, but you don't process properly. This happens to some of the veterans coming back from roadside explosions. Their brain is bopped around inside their head. Axons are torn, things get messed up. And this is another one of the things we do. In low vision, we also have a separate neuro rehabilitation for people who have had neuro damage. And we often work in conjunction, neuro with low vision rehabilitation. And that's one of the unique aspects of Western University is we have a neuro optometrist specialist working in that regard.
There. So macular degeneration, diabetes patients,
yep.
This is your specialty. If you've been told your glasses,
that's as good as they get.
Surgeries, we've done it all.
And I still don't like it. I don't see as well as I want.
Did they say that? They say, you know, I still can't see with my glasses.
Yeah. They don't say that. I keep wagging my finger at you.
Yeah,
I'm
go
sorry.
Ahead. No, go ahead.
Is that both fingers maybe?
No, that's, you're excited about it.
I am. So people don't say, they say these glasses don't work. These glasses aren't strong enough.
Okay.
And I say,
yeah, what do you say to that?
If I give me a hammer, I'll give you stronger glasses. You know, I'll go.
So you have a wisecrack to that.
Well, what I tell because I've got to get him out of that mindset.
So it's not the glasses.
It's not the glasses. These glasses work great, but maybe it's not appropriate for you. This is not the tool that's going to help you see better. This is not the tool that's going to allow you to live the life the way you want to do.
You have to update their glass prescription?
Oh boy, oftentimes, because part of the thing we talked about earlier was the low vision refraction technique. Okay, and so oftentimes we can, maybe 25–30% of the time, just doing a very careful low vision refraction.
That's not a surgical procedure.
It is not. It is just a different way of checking the power of the glasses. And it's something we teach all our students, but it takes a bit, it's a bit of an art form. And so to do it well, you have to do it a lot.
And do patients, I mean, at the end of this go, you know, why was I suffering for 5 years?
Yeah.
You know, nobody told me this.
It happens a lot.
How long does it take to turn something around? We're talking about in a perfect world, somebody that comes in, and you must have a favorite kind of a patient, right? Where they come in and they're just kind of hopeless, depressed, and you're the last resort.
I had a patient come in recently that the front desk told me, oh, be careful, this guy's got a really bad attitude.
All right, all right.
He turned into one of my best buddies. He didn't have a bad attitude. People who had taken care of him before had bad attitudes about him, and he took those on. He has a cane, but he comes in with a
a blind person cane.
Legally blind is not really blind.
Okay.
Okay. 3/4 of the legally blind can read with techniques and devices that we give them.
Okay.
Legal blindness is a legal term, much like legal insanity, perhaps you would say. Maybe they're not crazy, but they meet the criteria for the court systems. So legal blindness allows people to be eligible for aid, for SSI, for a number of things that can help supplement what they need while they get their lives back on track and able to do things. What I'm trying to do is free them from the shackles of their own limitations so that I can demonstrate to them the things they should be able to do.
For the sake of time, though, fast forward with that guy. What happens to that guy?
Oh,
that your staff warned you about.
Oh my gosh. He came in to pick up the device we had ordered for him. He was talking about the World Series. He was so excited he was able to see it. He had gotten, his health was going downhill because he refused to go out. His health was much better. His attitude was better. His family took me aside and told me how much more happy he was.
Good for you.
Because it was poisonous in the family when these things happen. People begin to backbite and blame. There is no blame with vision loss. Vision loss is just an is, you know. And so what we try to do is just free them from their shackles so that they can, once you
So his life is completely changed, obviously.
Oh yeah.
He can enjoy the last half of his life.
However long it lasts.
Last part.
Yeah. However long it lasts.
And he's a lot of people. I mean,
he is every man.
He's a lot of guys.
He is me when I get older.
And if you've been told that there's nothing else can be done, this is what you want.
That's our starting point.
Okay. Kids for just a moment, and we literally have to wrap it up.
Well, there's two main kinds of low vision people. Aging problems. It tears us all down. But also high-risk births or kids with genetic defects. So there's a lot of young people who are born with vision deficits that are difficult to overcome. And so if we work with them soon, we do two kinds of rehabilitation. One is the low vision rehabilitation to make the best use out of their physical abilities. Two is we'd use the vision therapy, which we have another department, Dr. Remick and her department, that teach them
how met her.
Good. Process visually. 80% of our knowledge comes through our eyes. So
get them in there early.
Get them in early, get them in often, teach them how to use what they have the best, and maximize not just their physical abilities, but their visual processing abilities.
Okay, good. And so premature baby, vision problems, they could keep kids alive now.
Right.
I guess one of the side effects is poor vision. But the assumption is they're being directed to the right doctors, this and that. But you're saying there's thousands, millions of these kids that are not maybe taking
Interestingly,
full advantage of what
the
can be
kids
done.
probably have better care than the seniors.
Okay.
Because the laws determine that they have to have vision evaluations and such. Now, that doesn't always mean they get low vision, or that doesn't always mean they get the vision therapy enhancements to their visual processing abilities, but it means that they're paid attention to more. So there's a higher chance that they'll be taken care of.
Okay. And
now there was a farm worker boy that we took care of, that his whole family just worked in the fields. He had vision loss. He was pretty much stuck. He couldn't do anything because he couldn't do that. But we saw that he had an ability. And so we were able to get him the devices and techniques. Just last year, he graduated with a bachelor's degree from Berkeley.
Nice. Very nice. So you have a lot of these. Okay, so to get started, they could visit your website, call the number at the bottom of the screen, and get started from there.
You bet.
All right. Well, I want to thank you for coming to the show. Very
What a pleasure it was talking to you.
Good stuff. Good stuff.
Thank
You've
you.
been watching The Wellness Hour, leader in medical news and information. I'm Randy Alvarez. If you would like to see this interview again online, you can visit our website at wellnesshour.com. Just put in low vision correction, or just low vision, or Dr. McAllister, if you could spell it. You say there's 51 different ways to spell it.
There are 51 ways to spell it.
We'll put about 20 different ways on our website.
There you go.
That way they'll
That's
still
the
find
ticket.
it. For now, I wish you good health.